The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Addressing the Prevention, Treatment, and Management of VTE in Pregnancy, a review of the 2018 ASH VTE Clinical Practice Guidelines. My name is Anita Rajasekhar, and I am an adult non-malignant hematologist at the University of Florida. I served on the guideline panel with Dr. Bates that developed these new guidelines, and I will be moderating today's webinar. Next slide. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every stage of life. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide. Today's presenter is Dr. Shannon Bates. Dr. Bates is a professor of medicine at McMaster University and director of the Division of Hematology and Thromboembolism. Dr. Bates chaired the panel for the 2018 ASH Clinical Practice Guidelines of VTE in the context of pregnancy. Next slide. The activity medical director for today's webinar is Dr. Andra James from Duke University. The planning committee for today's presentation include our presenter, Dr. Shannon Bates, and Dr. Barbara Conkle from the University of Washington, and James Munn from the University of Michigan. Next slide. In accordance with Creighton University Health Sciences Continuing Education Policy, the faculty and planning committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in the lecture. You may learn more about this at the Foundation's website, fwgbd.org. Next slide. So a little bit of housekeeping here. To ensure the best sound quality during the webinar, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with Dr. Bates at the end of the webinar. You can submit your questions during or after the presentation portion of the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen, and we will address them during the question and answer session at the end of today's presentation. Next slide. This learning activity is offered through the Creighton University Health Sciences Continuing Education, which has been accredited for 1.0 AMA credit for physicians and 1 contact hour for nursing professionals. Next slide. Okay, before we begin, we'd like to take a quick poll to see how many of you are with us today on the conference call. Please take a moment to answer the poll question on your screen. Okay, good. We'll give you a few more minutes here, a few more seconds here to allow some others to answer. Okay, we can go ahead and move on now. So the following are the learning objectives for today's webinar. For those who wish to refer to this later, we are recording the program and it will be archived on the website. And now I'd like to turn this over to Dr. Shannon Bates.
Thank you very much. So it's a pleasure today to present on the American Society of Hematology 2018 Guidelines for the Management of Venous Thromboembolism. During this presentation, I will cover the process for developing the ASH VTE Clinical Guidelines, as well as their strengths and limitations, discuss the clinical importance of and apply to practice the ASH VTE Clinical Guidelines, and where relevant, help you recognize and understand the differences and recommendations in these guidelines compared to those developed by other organizations. And we'll mostly be focusing on the 2012 American College of Chest Physician Guidelines. Next slide. Today I'll be presenting two cases and the relevant recommendations drawn from the guideline venous thromboembolism in the context of pregnancy on behalf of my panel co-authors as listed on this slide. I would note that the slides in this presentation are based on those from the ASH 2018 Guideline for the Management of Venous Thromboembolism educational slide set and are available to be downloaded. Next slide. The American Society of Hematology, or ASH, guidelines were developed in response to that organization's recognition of the need for a comprehensive set of guidelines on the prevention, diagnosis, and treatment of venous thromboembolism, or VTE, for hematologists and other healthcare providers. The goal of ASH's initiative was to produce and maintain evidence-based guidelines that will support healthcare providers and patients in making best care decisions. Next slide. The ASH Clinical Practice Guidelines on venous thromboembolism cover 10 topics in the diagnosis, prevention, and treatment of VTE as listed on this slide. The first 6 guidelines, colored in purple, were published on November 27, 2018, including the guideline about which we will discuss today, VTE in the context of pregnancy. Next slide. The ASH guidelines were developed in partnership with the McMaster GRADE Centre, a world leader in guideline development. Development of the ASH Clinical Practice Guidelines on venous thromboembolism was a multi-year process that started in 2015 with establishment of 10 guideline panels and ended with publication of the first guideline documents in late November 2018. Next slide. The 2018 ASH VTE guidelines were developed using state-of-the-art methodology to ensure that they meet the highest standards for trustworthiness and transparency. ASH vetted potential panel members and appointed them to the guideline panel, while the McMaster GRADE Centre vetted and retained researchers to conduct systematic reviews of evidence and coordinate the guideline development process. The panel for this specific guideline included hematologists, obstetricians, a specialist in maternal fetal medicine, internists, a pharmacist with clinical research expertise on the guideline topic, methodologists with expertise in evidence appraisal and guideline development, and 2 patient representatives. Financial and intellectual conflicts of interest for all participants were managed according to ASH policies based on recommendations of the Institute of Medicine and the Guidelines International Network. The guideline panel brainstormed and then prioritized relevant questions. Evidence on health effects, resource use, feasibility, acceptability, equity, and patient values and preferences was retrieved from the literature and synthesized. The panel used the GRADE approach to assess the strength or certainty of the evidence and to formulate recommendations. These guidelines and the associated documents were made available for public consultation before being finalized and submitted for peer reviewed and then eventually published. Next slide. The strength of the recommendations in this guideline is expressed as either strong or conditional. Conditional was formally termed weak. If it's a strong recommendation, then the recommendation will state the guideline panel recommends. If it's a conditional recommendation, the recommendation will state the guideline panel suggests. A strong recommendation means that most individuals in this situation would want the recommended course of action and that most individuals should simply follow this recommended course of action. On the other hand, a conditional recommendation means that the majority of individuals would want the suggested course of action, but many would not. Different choices will be appropriate for individual patients, and clinicians must help patients arrive at a management decision consistent with his or her values and preferences. Next slide. So let's start with some background to this topic. Venous thromboembolism complicates approximately 1.2 of every 1,000 deliveries. Despite these low absolute risks, pregnancy-associated venous thromboembolism is a leading cause of maternal morbidity and mortality in Western countries. The risk of pregnancy-associated venous thromboembolism spans all 3 trimesters, although the risk seems highest in the 3rd trimester and may persist for up to 12 weeks postpartum, although women are more likely to develop venous thromboembolism during the first 6 weeks after delivery than during the next 6 weeks. A pooled analysis suggests that the absolute risk of venous thromboembolism is equal during the antepartum and postpartum periods at 0.6 per 1,000 pregnant women. However, because the postpartum period is much shorter than the antepartum period, the daily risk of venous thromboembolism is higher following delivery than before delivery. The diagnosis, prevention, and treatment of pregnancy-associated venous thromboembolism are particularly challenging because of the need to consider fetal as well as maternal well-being. Next slide. Today I'm going to focus on recommendations related to the treatment and prevention of venous thromboembolism. I will not be addressing those related to diagnosis. So let's start with our first case. She is a 32-year-old female, 28 weeks into her first pregnancy, who presents with a 48-hour history of new left leg pain and swelling. She has no symptoms of pulmonary embolism. Physical examination demonstrates unremarkable vital signs. However, her left leg is warm and swollen. You arrange for an ultrasound of that leg, and the radiologist reports occlusive thrombus in the left common femoral vein. Next slide. Given these ultrasound findings, what anticoagulant would you suggest for the treatment of this pregnancy-related deep vein thrombosis? And we won't be giving you, members of the audience, a chance to answer these questions directly to us. We'll provide the answer, but let's first consider our options. Subcutaneous unfractionated heparin, a direct oral anticoagulant, low molecular weight heparin once or twice daily with anti-10A monitoring, or low molecular weight heparin once or twice daily without anti-10A monitoring. Please reveal the answer. Based on available evidence and consideration of patient, physician, and societal values and preferences, our panel suggested low molecular weight heparin once or twice daily without anti-10A monitoring. Let's examine some of the evidence. Next slide. During pregnancy, when possible, one would like to avoid agents that cross the placenta and have the potential to impact on the fetus. The vitamin K antagonists like warfarin, the direct thrombin inhibitors and direct 10A inhibitors, and the penosaccharides like fondaparinux have all been shown to cross the placenta and so have the potential to cause bleeding in the fetus and teratogenicity. The effects of warfarin are best known and include spontaneous pregnancy loss. Warfarin embryopathy is fused between weeks 6 and 12, central nervous system abnormalities, and perhaps minor neurologic dysfunction with exposure during other time periods, as well as neonatal hemorrhage if used close to term. The direct oral anticoagulants and the penosaccharide fondaparinux have not been well evaluated in pregnancy. In animal studies, all of the direct oral anticoagulants, dabigatran, rivaroxaban, apixaban, and edoxaban, have been shown to cross the placenta, although the amount transferred is less with dabigatran. Animal reproductive toxicity has been demonstrated with dabigatran, rivaroxaban, and edoxaban, but not with apixaban. That said, the package inserts for all of these medications state that they should be avoided in pregnancy. Small amounts of pharmacovigilance data for women inadvertently exposed during pregnancy has been published. Most of this pertains to rivaroxaban. Given the limited numbers of affected pregnancies, all we can reasonably conclude is that there doesn't appear to be a high risk for a direct oral anticoagulant embryopathy, but we cannot confirm no risk and safety during pregnancy. There are reports of the successful use of the penosaccharide during pregnancy. However, in almost all of these cases, use was commenced in the 2nd and 3rd trimester. Given these potential fetal risks, the use of alternative anticoagulant agents that do not cross the placenta has been advocated. There is evidence that unfractionated heparin, low molecular weight heparin, and the heparinoids like dinaproid do not cross the placenta and are not associated with an increased risk of adverse fetal or neonatal outcomes. Unfortunately, all of these drugs require subcutaneous injections. In non-pregnant patients, low molecular weight heparin is at least as safe and as effective as unfractionated heparin for both treatment and prevention of venous thromboembolism. However, low molecular weight heparins have potential advantages over unfractionated heparin, including a longer plasma half-life and more predictable dose response with the potential for once-daily administration, less risk of heparin-induced thrombocytopenia, and a reduced risk of heparin-associated osteoporosis. Next slide. Based on this information, the panel recommends low molecular weight heparin over unfractionated heparin. The panel also suggests that either once or twice daily low molecular weight heparin is acceptable. The considerations that led to that suggestion are as follows. First, in the non-pregnant population, a 2013 systematic review and meta-analysis compared once per day with twice per day low molecular weight heparin dosing in patients with acute venous thromboembolism and found no significant difference in the risk of recurrence or major bleeding. Now, it's important to recognize that it's entirely possible that these results are not generalizable to pregnant women, given changes in pharmacokinetics that occur during pregnancy. However, 2 observational studies in pregnant women with proven venous thromboembolism treated with either once or twice per day low molecular weight heparin found an overall low incidence of recurrent venous thromboembolism and bleeding with no clear difference between dosing schedules. Based on the limited body of available low certainty or weak evidence, it is difficult to draw significant conclusions regarding a balance of benefits or harms with respect to once versus twice daily dosing. Therefore, the panel was unable to make a recommendation in favor of either intervention and instead considered that it's a reasonable option to use either regimen and that individual treatment decisions should be made using a shared decision-making model between patient and clinician. That said, the smaller number of injections required with once daily low molecular weight heparin might increase feasibility and acceptability of treatment in pregnancy. Next slide. During pregnancy, changes occur that may affect low molecular weight heparin dosing requirements. The pregnant woman gains weight and there is an expansion of intravascular plasma volume as well as extravascular water content, potentially increasing the volume of distribution of any given drug. As you'll recall, low molecular weight heparin is excreted renally. In healthy women, the glomerular filtration rate increases by 50% at the end of the first trimester. All of these changes have the potential to increase low molecular weight heparin dosing requirements in this population. The need for dose adjustment in reaction to these changes, however, remains controversial. Some advocate for the performance of periodic anti-10A low molecular weight heparin levels with dose adjustment to maintain a therapeutic level. However, we know that there are issues with reliability and availability of anti-10A assays, as well as drawbacks of cost and the need for frequent blood tests. There is no validated anti-10A low molecular weight heparin range in pregnancy. Clinical outcome data in this population are very limited. However, a single center case series including 2 consecutive groups of pregnant women treated with low molecular weight heparin for venous thromboembolism sustained in the index pregnancy either with or without low molecular weight heparin monitoring showed no significant differences between those admittedly 2 small groups with respect to maternal blood loss at delivery, recurrent thromboembolism, or planned delivery. Given the lack of evidence of a benefit to anti-10A monitoring in this patient population and the limitations and drawbacks I've mentioned, the panel suggested against routine monitoring of anti-10A levels to guide low molecular weight heparin dosing for the treatment of venous thromboembolism in pregnancy. Next slide. As a physician, your next question would be whether or not to admit your patient. Evidence from the non-pregnant population with deep vein thrombosis or low-risk pulmonary embolism found no increased risk of recurrent venous thromboembolism, major bleeding, or mortality in those patients treated as outpatients or discharged early compared with those treated as inpatients. Some investigators reported a high degree of patient satisfaction, better patient social functioning, and reduced expenditures for the healthcare system with outpatient treatment of venous thromboembolism in the general population. Unfortunately, similarly robust data are lacking for pregnant women with acute venous thromboembolism. However, small observational studies in the pregnant population also suggested no increased risk for appropriately selected patients. Therefore, based on the body of available evidence and other criteria, the panel concluded that it is likely that outpatient therapy is as beneficial as hospital-based treatment with improved acceptability and resource use and with no appreciable increase in harm for low-risk patients. As such, we suggested initial outpatient therapy over hospital admission for pregnant women with low-risk acute venous thromboembolism. In our deliberations, we considered that the requirement for safe outpatient therapy would include not only appropriate patient selection, but patient education, adequate follow-up, and availability of an on-call service. Patients considered higher risk, that is, those late in gestation, with vital sign abnormalities, or severe pain requiring analgesia, extensive venous thromboembolism, maternal morbidities that limit tolerance for recurrent venous thromboembolism are associated with a high risk of bleeding, contraindications to low molecular weight heparin, or lack of adequate support at home would benefit from at least initial hospitalization. And certainly where the expertise for patient training and outpatient monitoring of therapy does not exist, even low-risk patients would benefit from initial hospitalization. Next slide. So here we have another question. Your patient has done well on once daily, unmonitored low molecular weight heparin with dosing based on weight. She is now 35 weeks pregnant and interested to know how her anticoagulants will be managed around the time of delivery. She would prefer to have a vaginal delivery with epidural analgesia. What would you suggest? So your options are switch anticoagulation to intravenous heparin, then arrange for a scheduled or induced delivery with discontinuation of intravenous heparin 6 hours before, scheduled or induced delivery with discontinuation of low molecular weight heparin 24 hours before, allow for spontaneous labor before stopping low molecular weight heparin, a scheduled cesarean section with discontinuation of low molecular weight heparin 24 hours before, or stopping of the patient's low molecular weight heparin now as she no longer requires anticoagulants for her deep vein thrombosis. Please reveal the answer. And the correct answer is B, a scheduled or induced delivery with discontinuation of low molecular weight heparin 24 hours before. So again, let's review some of the evidence behind that recommendation. Next slide. To start with, there are no randomized trials specifically addressing this issue, and so our recommendation is based on a number of considerations. First, observational data suggests a possible increase in postpartum hemorrhage if therapeutic anticoagulation is held with spontaneous onset of labor compared to planned delivery. We also need to be aware that North American anesthesia guidelines specify a minimum of 24 hours between the last dose of therapeutic low molecular weight heparin and placement of an epidural catheter. It's also important to note that there has not been shown to be an association between induction of labor and maternal or fetal harm, including increased need for cesarean section, as demonstrated in multiple randomized studies and systematic reviews. So based on that, For pregnant women receiving therapeutic dose low molecular weight heparin for treatment of venous thromboembolism, the panel suggested scheduled delivery with prior discontinuation of anticoagulant therapy. We noted that other options for anticoagulant management, including conversion to intravenous unfractionated heparin with cessation 4 to 6 hours prior to delivery or anticipated need for epidural insertion, with repeat activated partial thromboplastin time drawn after 4 hours to confirm normalization, would be entirely appropriate in patients considered at high risk for recurrent venous thromboembolism with prolonged anticoagulant interruption. And these types of patients would include those with proximal deep vein thrombosis or pulmonary embolism diagnosed 2 to 4 weeks prior to delivery. Next slide. Your patient undergoes a scheduled induced vaginal delivery. Anticoagulants can now be restarted, and you know that although your patient has already received 3 months of anticoagulant therapy, she will require 6 weeks of postpartum anticoagulation to take her through the highest risk period for pregnancy-associated venous thromboembolism. She would like to breastfeed. Which one of the following anticoagulants is contraindicated? Fondaparinux, low molecular weight heparin, dinaproid, rivaroxaban, or warfarin. Please reveal the correct answer. The correct answer is D, rivaroxaban. Next slide. When discussing the safety of anticoagulants while breastfeeding, the general principle is that you would like to avoid those agents that are either excreted into the breast milk or have the potential for oral absorption by the infant. Neither warfarin nor acenocumarol, which is commonly used in Europe, is detected in breast milk, and neither medication induces an anticoagulant effect in breastfed infants when nursing mothers consume the drug. Fenprocumin, another vitamin K antagonist with a long half-life that is widely used outside of North America, is more lipophilic than warfarin and acenocumarol, and so can it be excreted into the breast milk. Although since it is highly protein-bound, the amounts detected are small. Given the above, warfarin and acenocumarol are safe to use in this setting, but fenprocumin should be reserved only for breastfeeding women who are unstable on short-acting acenocumarol in countries where warfarin is not available. Unfractionated heparin is not excreted into the breast milk. Although small amounts of low molecular weight heparin have been found in breast milk, this agent has very low oral bioavailability. Similarly, a small number of case reports have reported no or very low activity in the breast milk of women receiving dinaproid. There are no published data on the excretion of fondaparinux into breast milk. However, significant absorption by breastfeeding infants is again unlikely given low oral bioavailability. Therefore, unfractionated heparin, low molecular weight heparin, fondaparinux, and dinaproid were considered by the panel as safe options for breastfeeding women. As judged by rivaroxaban, the oral direct 10A inhibitors have the potential to be excreted into the breast milk, and these agents could be absorbed by nursing infants and so should be discontinued in breastfeeding women. There is no clinical data on excretion of the direct thrombin inhibitor dabigatran. However, given the potential for oral absorption, this drug should also be avoided. As such, the panel recommended against the direct oral anticoagulants in breastfeeding women. Next slide. Your patient completes 6 weeks of postpartum anticoagulant prophylaxis without incident, and post-discontinuation has no issues with recurrent venous thromboembolism. 3 years later, she informs you that she is 10 weeks pregnant with her second child. She's concerned about developing venous thromboembolism again during pregnancy. What would you recommend for prophylaxis? No prophylactic anticoagulation? Serial bilateral leg ultrasounds and treatment only if recurrent deep vein thrombosis is diagnosed? Antepartum anticoagulant prophylaxis only? Postpartum anticoagulant prophylaxis only? Or antepartum and postpartum anticoagulant prophylaxis? Please reveal the correct answer. The correct answer is E, antepartum and postpartum anticoagulant prophylaxis. Next slide, please. The panel recommendations are included on this slide. It's important to note that these recommendations were based on a panel-determined acceptable venous thromboembolism risk threshold of 2% antepartum and 1% postpartum. The ASH Guideline Panel recommends antepartum prophylaxis over no anticoagulant prophylaxis for women not receiving long-term anticoagulant therapy who have a history of venous thromboembolism that was either unprovoked, where the antepartum risk is 3.6%, or associated with a hormonal risk factor, where the antepartum risk is 6.4%. For women not already receiving long-term anticoagulant therapy who have a history of prior venous thromboembolism associated with a non-hormonal temporary provoking risk factor and no other risk factors, the ASH Guideline Panel suggested against antepartum anticoagulant prophylaxis, as our risk estimate suggested that the risk was 1.1%, so less than our 2% threshold. Postpartum prophylaxis is recommended for all women not receiving long-term anticoagulant therapy who have a history of prior venous thromboembolism, regardless of the nature of the provoking risk factor, as our risk estimates suggested a risk of recurrence of 6.5% during this time frame. Next slide. So this slide summarizes some of the available data that we have for us. This slide focuses on antepartum prophylaxis. And again, as I mentioned, available data suggests that the history of venous thromboembolism increases the risk of antepartum venous thromboembolism from our baseline of 0.6 per 1,000 deliveries. Overall, in all pregnant women with a prior history of venous thromboembolism, the risk appears to be approximately 4.2% if no prophylaxis is given. As we discussed, in those with an unprovoked event, the antepartum risk is 3.6%, with a hormonally related event, 5.6% or 6.4%, and with a provoked non-hormonal risk factor, 1.1%. Data from other studies in which women with prior venous thromboembolism were provided with prophylaxis suggest an antepartum risk of venous thromboembolism of 0.9%, or an approximately 75% risk reduction. Prophylactic low molecular weight heparin does not appear associated with an increased risk of major antepartum or postpartum hemorrhage, osteoporosis, or thrombocytopenia. However, the requirement for daily injection throughout the duration of pregnancy and the cost of this intervention may pose a burden for some. Using the available evidence and our risk threshold of 2%, our guideline panel therefore determined, as I previously mentioned, that although the certainty of evidence is low, there appears to be a net health benefit from using antepartum prophylaxis for the prevention of recurrent venous thromboembolism, with the exception of women who had a temporary non-hormonal risk factor at the time of their prior event and have no concurrent additional risk factors for venous thromboembolism. Next slide. As I mentioned, postpartum venous thromboembolism affects approximately 6.5% of pregnancies in women with a history of venous thromboembolism. There was no information in the literature available on the risk of postpartum venous thromboembolism in subgroups of women according to risk factors present at the time of their incident event. In women with a history of venous thromboembolism who were treated with postpartum prophylaxis, the risk of postpartum venous thromboembolism was substantially lowered to 1.8%. The risks of major peripartum and postpartum bleeding with low molecular weight heparin prophylaxis following delivery were similar in those to women not receiving prophylaxis. Although the data is of low certainty, based on available evidence in this population, extrapolating from other populations, and using our panel's venous thromboembolism risk threshold and other criteria, the panel felt it was likely that prophylactic anticoagulation postpartum reduces the risk of developing venous thromboembolism with low risk of harm. Therefore, the panel chose to make a strong recommendation in this setting. Next slide. After careful consideration, your patient is started on antepartum and postpartum anticoagulant prophylaxis with prophylactic dose low molecular weight heparin. Her pregnancy proceeds without complications or signs or symptoms of recurrent venous thromboembolism. So to summarize the messages from our first case, low molecular weight heparin, next slide, please. Low molecular weight heparin dosed either once or twice daily without routine anti-10A monitoring is the preferred treatment for acute venous thromboembolism in pregnancy. Pregnant women who are receiving therapeutic low molecular weight heparin for pregnancy-associated venous thromboembolism should have a scheduled delivery to facilitate neuroaxial analgesia and reduce bleeding risk. Women with previous unprovoked venous thromboembolism or venous thromboembolism provoked by hormonal risk factors should receive antepartum and postpartum anticoagulant prophylaxis. And women with previous venous thromboembolism provoked by a transient non-hormonal risk factor require postpartum prophylaxis only as long as there are no other significant venous thromboembolism risk factors. The first, third, and fourth recommendations are essentially unchanged from those in the last American College of Chest Physicians Guidelines of 2012. The second recommendation is different as the American College of Chest Physicians did not make specific recommendations regarding the need for scheduled delivery or not. Next slide. Our second case is that of a 32-year-old female who is 12 weeks into her first pregnancy. She has no significant past medical history and specifically no history of venous thromboembolism. However, there is a family history of venous thromboembolism in that her mother was diagnosed with postpartum pulmonary embolism at age 32 years. Subsequent thrombophilia testing revealed the patient's mother to have antithrombin deficiency with reduction in functional antithrombin levels to 0.5 units per milliliter with a normal reference range of greater than 0.8 units per milliliter. Next slide. Given this information, what would you suggest for your patient for prevention of pregnancy-associated venous thromboembolism, given that when you arranged for testing, your patient was found to have an antithrombin level of 0.58 units per milliliter, again with a normal range of at least greater than 0.80 units per milliliter. You know that although pregnancy can result in some decreases in antithrombin level, this is a greater reduction than might be expected, and her levels are consistent with those of her mother. Therefore, you elect to treat your patient as if she has antithrombin deficiency, but make a note to retest her when she is greater than 6 weeks postpartum in order to confirm the diagnosis. So your options for your patient are no prophylactic anticoagulation, serial bilateral leg ultrasounds and treatment only if deep vein thrombosis is diagnosed, antepartum anticoagulant prophylaxis only, postpartum anticoagulant prophylaxis only, or antepartum and postpartum anticoagulant prophylaxis. Next slide. The correct answer is antepartum and postpartum prophylaxis only. Thank you. So on this slide, we have the panel recommendations for the first group of hereditary thrombophilias. As you can see, the recommendations are divided into those based on whether or not the patient has a family history of venous thromboembolism, and we provide recommendations for antepartum prophylaxis and for postpartum prophylaxis. Recommendations for prophylaxis were based on a venous thromboembolism risk threshold of the same as before, 2% antepartum and 1% postpartum. The panel suggested against antepartum and postpartum prophylaxis for those with heterozygosity for the factor V Leiden or prothrombin gene mutation, regardless of family history, and for those with antithrombin, protein C deficiency, or protein S deficiency and no family history of venous thromboembolism. As for all of these patients, the antepartum and postpartum risks were estimated to be each less than 1%. Postpartum prophylaxis was suggested for those with protein C and S deficiency with a positive family history, as the postpartum risks were 1.1% and 1.8% respectively, so greater than our 1% postpartum threshold. For women with antithrombin deficiency and a positive family history of venous thromboembolism like our patient, the antepartum estimated risk was 2.7% and the postpartum estimated risk was 4.8%. As both of these exceeded our thresholds, there was a recommendation for postpartum prophylaxis and a suggestion for antepartum prophylaxis. Next slide. Here are the recommendations for the other thrombophilias. The panel suggested antepartum and postpartum prophylaxis for women with combined thrombophilias regardless of family history, and for those homozygous for the factor V Leiden mutation regardless of family history. Homozygosity for the factor V Leiden mutation in the presence of a positive family history is actually thought to be the highest risk thrombophilia, with antepartum risks of 6.9% and postpartum risks of 5.9%. Recommendations for homozygosity for the prothrombin gene mutation were more complicated. For those without a family history, the antepartum and postpartum risk estimates were each 1.6%, exceeding the postpartum but not antepartum risk thresholds. For those with a family history, no family data were available. The panel reasoned in this situation that the postpartum risk in this situation was likely to be at least equal to those without a family history and made a conditional recommendation for prophylaxis, as the risk exceeded our postpartum threshold of 1.1%. Given the antepartum risk in those without a family history did not exceed the risk threshold, similar logic could not be used. And in the absence of any data, a formal recommendation could not be issued. However, in discussions, panel members noted that they would likely provide antepartum prophylaxis in this setting, given that the 1.6% risk in those without a family history was close to our risk threshold, and the risk was likely to be higher in those with a family history. Next slide. You've determined that your patient requires antepartum and postpartum anticoagulant prophylaxis given her family history and thrombophilia. What dose of prophylactic low molecular weight heparin is suggested for patients requiring antepartum and postpartum prophylaxis? And your options are standard dose, prophylaxis, antepartum and postpartum, standard dose prophylaxis, antepartum and intermediate dose postpartum, therapeutic dose antepartum and intermediate dose postpartum, intermediate dose antepartum and therapeutic dose postpartum. And if you could reveal the answer. So here I was a bit unfair because there are two correct answers, A and B, standard dose antepartum and either standard or intermediate dose postpartum. Next slide. So let's look again at some of the data. Relevant information is very limited. There were no clear data showing a benefit to the use of intermediate dose low molecular weight heparin, either antepartum or postpartum. There was some data to suggest that there may be a higher risk of antepartum bleeding and bleeding around the time of delivery in women receiving higher than prophylactic dose low molecular weight heparin antepartum. Admittedly, the certainty of these risk estimates was low. The same risks were not seen postpartum. There were also some concerns amongst the guideline panel members about reduced access to epidural analgesia with higher than prophylactic dose low molecular weight heparin antepartum. As such, we felt that there was an unclear net health benefit for using intermediate dosing of low molecular weight heparin compared to prophylactic standard dose antepartum. The panel considered that both dosing options would lead to net desirable consequences after delivery, given the increased thrombotic risk during this time period. As such, the panel agreed that a conditional recommendation against intermediate dose prophylactic low molecular weight heparin prior to delivery was warranted, but that either dosing option was acceptable after delivery. This, of course, is a conditional recommendation, meaning that other options may be reasonable. And certainly, Some experts might favor a higher than prophylactic dose in patients with antithrombin deficiency and a positive family history. And this would be a very reasonable choice as long as all of the potential benefits and risks were taken into account. Next slide. After discussing the potential benefits and risks, you and your patient elect to proceed with standard dose prophylactic low molecular weight heparin, both antepartum and postpartum. She does well with this strategy and has no difficulties with venous thromboembolic or bleeding complications. You are now assessing her at 35 weeks. Next slide. Your patient is worried about how prophylaxis will affect her delivery. She hopes to have a vaginal delivery with epidural analgesia. What would you suggest for management of her prophylactic low molecular weight heparin around the time of delivery? A, switch anticoagulation to intravenous heparin, then arrange for a scheduled delivery with discontinuation of intravenous heparin 6 hours before. Scheduled delivery with discontinuation of low molecular weight heparin 24 hours before. Allowing for spontaneous labor before stopping low molecular weight heparin. Scheduling cesarean section with discontinuation of low molecular weight heparin 24 hours before. Stopping of low molecular weight heparin now as she no longer requires anticoagulation. Please reveal the answer. The correct answer here is allow for spontaneous labor before stopping low molecular weight heparin anticoagulation. Next slide. In pregnant women receiving prophylactic dose low molecular weight heparin, the panel suggests against scheduled delivery with discontinuation of prophylactic anticoagulation compared to allowing spontaneous labor. So again, no randomized trials addressing this question. The guideline panel considered that allowing spontaneous labor may minimize the need for medical intervention in labor and potentially avoid maternal and neonatal complications, as well as increased medicalization of delivery that might be associated with induction of labor. Further, available evidence does not demonstrate a consistent effect of prophylactic anticoagulation on bleeding risk. Current North American and European anesthetic guidelines call for at least a 12-hour interval between the last dose of prophylactic low molecular weight heparin and placement of an epidural catheter. In general, the panel considered that the 12-hour recommended interval between the last dose of standard prophylactic low molecular weight heparin and placement of a catheter for neural axial analgesia would allow most women receiving standard dose prophylactic low molecular weight heparin the option of neural axial analgesia regardless of whether the delivery was scheduled or spontaneous. Additionally, advising women that they can forego a dose of prophylactic low molecular weight heparin until their case has been reviewed, if they happen to think they have entered labor spontaneously, may improve their access to neural axial analgesia. Certainly, the data informing this recommendation are of low certainty, and this decision may be heavily influenced by patient and clinician preferences. Scheduled delivery may be preferable for those who place a very high priority on access to epidural for analgesia, or when there is a high risk of birth by cesarean section so that general anesthesia can be avoided. Next slide. Your patient continues prophylactic low molecular weight heparin and opts for spontaneous labor scheduled delivery. At 39 weeks gestational age, she develops regular contractions. She stops her prophylactic low molecular weight heparin at that point and presents to hospital. 14 hours later, she is progressing in labor and an epidural catheter is inserted with no difficulty. Labor is uneventful and prophylactic low molecular weight heparin is resumed postpartum when hemostasis is achieved. Next slide. So this slide summarizes the recommendations that were put forth for case 2. Pregnant women with no personal or history of venous thromboembolism may merit anticoagulant prophylaxis depending on their family history of venous thromboembolism and whether or not there is a thrombophilia. In general, prophylaxis is not recommended for women with thrombophilia and no personal or family history of venous thromboembolism unless they are homozygous for the factor V line mutation or carry a combined thrombophilia, in which case antepartum and postpartum prophylaxis is recommended. And for those who are homozygous for the prothrombin gene mutation, only postpartum prophylaxis is recommended, even without a family history. For those with a family history of venous thromboembolism, antepartum and postpartum prophylaxis is suggested for those with antithrombin deficiency, combined thrombophilias, and homozygosity for the factor V Leiden mutation. The panel suggested at least postpartum prophylaxis in those with homozygosity for the prothrombin gene mutation, but was not able to issue an evidence-based recommendation for antepartum prophylaxis in the absence of any data. However, an informal suggestion for prophylaxis was made. Standard dose prophylaxis is suggested antepartum, while either standard dose or intermediate dose prophylaxis are acceptable postpartum. And finally, pregnant women who are receiving prophylactic dose low molecular weight heparin do not necessarily require a scheduled delivery. Of those recommendations, the latter is new since the 2012 ACCP guidelines. The ACCP guidelines suggested either intermediate or standard dose prophylaxis, both antepartum or postpartum. The thrombophilia recommendations have several differences. The suggestion that no postpartum prophylaxis is required for patients heterozygous for the factor V Leiden mutation or prothrombin gene mutation and a family history of venous thromboembolism is new, as is the suggestion for antepartum prophylaxis, in addition to postpartum prophylaxis for those with antithrombin deficiency or combined heterozygosity and a family history of venous thromboembolism, or homozygosity for the factor V Leiden mutation in the absence of a family history of venous thromboembolism. Next slide. Our recommendations have guided you through the management of a case of treating pregnancy-related deep vein thrombosis and preventing pregnancy-related deep vein thrombosis. Our chapter made a number of other guidelines not covered in this session that are listed on this slide with respect to management of proven superficial vein thrombosis in pregnancy, prophylaxis in women undergoing assisted reproduction, prophylaxis in pregnant women with clinical risk factors. Next slide. The use of catheter-directed thrombolysis for deep vein thrombosis in pregnancy, thrombolysis for pulmonary embolism in pregnancy. Next slide. And the diagnosis of pregnant women with suspected pulmonary embolism or suspected deep vein thrombosis. Next slide. In conclusion, I'd like to acknowledge all of the work of my ASH Guideline Panel team members, the Knowledge Synthesis team members, and the McMaster University GRADE Centre. You can see more about our ASH VTE guidelines at www.hematology.org/VTE, and there is an ASH VTE Guidelines mobile app available for downloading. Thank you very much. And I'll turn things back over to our moderator.
Okay, thank you very much, Dr. Bates, for your up-to-date, informative presentation on prevention and treatment of VTE in this challenging patient population. A hearty congratulations to you on leading a rigorously performed guideline and crafting recommendations that we hope will inform healthcare providers in their daily practice. And it's clear that there's a dearth of data in this population and an opportunity for some much needed research to answer some of these clinical questions definitively. For our audience, the Foundation is pleased to provide this webinar and continuing education credits at no cost to the attendees, and you will receive the evaluation immediately following this program and will include details on requesting CE credit. Next slide. At this time, we will proceed with the question and answer part of our program. As a reminder, participants can submit questions via the chat box in your GoToWebinar control panel. So going through the questions here, we have our first question for you, Dr. Bates, and this is regarding the thrombophilia prophylaxis recommendation, and I think we knew this might be a controversial topic. So the first question here is, since protein C and S are considered intermediate risk factors generally, and factor V Leiden and prothrombin gene heterozygosity are low risk, why are they handled the same with respect to prophylaxis?
Well, let me clarify, because they're not handled exactly the same. First off, the only situation where they're handled the same is in those patients without a family history of venous thromboembolism. And in that situation, regardless of the strength of the thrombophilia, the risk of venous thromboembolism is exceptionally low, less than 1%. And in essence, these are likely women who were either screened inadvertently or screened in the past when we thought that these thrombophilias were related to pregnancy complications. In patients with a family history of venous thromboembolism, that's a different situation. So again, our low-risk thrombophilia, heterozygosity for the factor V Leiden and prothrombin gene mutation. With our data and with our method of pooling the data, our risk estimates were less than 1% antepartum and postpartum. So again, we suggested no prophylaxis. However, for women with a family history of venous thromboembolism who have protein C or S deficiency, we actually suggested postpartum prophylaxis in both of those groups, as the risks of venous thromboembolism in those patient populations exceeded our threshold of 1%.
Okay, another question we have, I think we knew might pop up because of the multidisciplinary nature of this chapter. What is your thoughts on OB's preference to switch to sub-Q heparin at 36 weeks? Despite recommending continuing low molecular weight heparin, many OBs want to continue to switch patients at 38 weeks to heparin.
Right. So I think there's two scenarios. So the first is if the patient is receiving therapeutic dose anticoagulation. And if someone is receiving twice daily therapeutic dose unfractionated heparin, there is evidence from a cohort study that suggests that this low molecular weight heparin, or this unfractionated heparin, actually acts as a depot of anticoagulant that continues to release unfractionated heparin over time. So in that study, women who were receiving twice daily therapeutic dose unfractionated heparin had therapeutic levels of unfractionated heparin as judged by activated partial thromboplastin time for up to 28 hours post their last injection. And the problem is that with this depot effect, you can't immediately neutralize that unfractionated heparin with protamine sulfate. You'll either have to give repeated doses or try and figure out how to give an infusion. So it's not clear to me that with therapeutic dosing of unfractionated heparin, that changing over to that agent actually solves any of the problems that we have with low molecular weight heparin with respect to needing a planned delivery. With respect to using unfractionated heparin in prophylactic doses at 36 weeks, that may allow for a shorter time interval between the last injection and epidural analgesia, because current guidelines call for about 4 to 6 hours between the two. However, it's important to note that it is increasingly difficult to obtain unfractionated heparin as an outpatient. Patients have to take it twice a day, and they also have to draw up their own syringes. So it's not clear to me that the benefits of switching over outweigh the drawbacks, which is why we did not make that recommendation or suggestion. And Dr. James has mentioned that the American College of Obstetricians and Gynecologists, who have previously advocated for switching over to unfractionated heparin close to term, are going to be removing that recommendation.
Another question that comes up here is, does the stopping point for low molecular weight heparin therapeutic doses prior to delivery differ between those who are taking once or twice daily dosing?
Yes, but most anesthetists will still want that 24-hour time interval. So for people who are taking twice daily low molecular weight heparin, if they would take their last dose presumably the morning of the day prior to admission for induction. Whereas if you're taking once daily low molecular weight heparin, you would either wind up taking your last dose in the evening 2 days prior to admission for induction, or you would wind up taking your acute 12-hour dose the morning of the day prior to induction, unless the women's induction and need for epidural analgesia were thought to be closer to the end of the day of admission.
Okay, and I think we have time for one last question here. Most of the recommendations that are conditional are based on low or very low quality of evidence. Can you speak to how the panel can arrive at a strong recommendation despite having low quality of evidence? For example, the question on antepartum prophylaxis in patients with a history of unprovoked or hormone-provoked VTE.
So that's an excellent question, and there was a lot of discussion amongst our guideline panel. And if you happen to have the opportunity to read the guideline document, you'll see that there's an explanation behind that. So the panel was split as to the strength of the recommendation. And the strength of the recommendation is not only based on the evidence, it's based on other considerations. It's based on the thought of whether or not additional research is required for the panel members to feel that that intervention is in the best interest of most, if not all, patients. And for each of these recommendations where there was a debate about whether the recommendation should be conditional or strong when the evidence was weak, we did in the guideline panel or in the guideline document make note of what that vote was. So for many of these recommendations, there was not 100% agreement that it should be a strong recommendation. The panel was often split, but where the majority voted for a strong recommendation, that's what we went with.
Okay, thank you. That's all the time we have for questions today. As a reminder, you will be able to review this webinar for your reference or share today's proceedings with your colleagues by visiting fwgbd.org and accessing this webinar under the Archived Webinars section. For those who may have questions on this material following today's program, we encourage you to visit our Ask the Experts feature on our website and submit your questions online. Next slide. And before we go, please mark your calendars for our next webinar on March 7th, featuring Drs. Marilyn Tellen and Andrew James on sickle cell disease. Next slide. And with that, we all thank you for your attendance, and we look forward to your participation in future Foundation programs. Thank you very much.